Hello, everyone. Welcome to another episode of Grounded in Groundshot podcast. I'm your host, Dr. Vishal Gewali, a medical oncologist from Queen's University, Kingston, Canada. Welcome again to this new episode. Today, actually, I'm at a hotel in Montreal. I'm here for the CSO annual meeting, and today's guest is someone who I hugely respect. He's like a father figure for me in oncology. He has inspired me a lot. I have learned a lot from talking to him, reading his articles, and listening to his lectures. He is Professor Ian Tannock, one of my role models in oncology. I have been trying to get this interview with Ian for a long time now, but I prefer doing this in person. So today was a great opportunity. We are both here for the CSO annual meeting. And I think the audience may not know this. One of the reasons why I'm in Kingston at Queen's University is actually Ian Tannock. I was at Harvard doing my fellowship, and I had an offer to come to Queen's. And I was debating whether or not to take up on that offer. And I had not made up my mind yet. And I did not know Ian Tannock at the time. And he's from Princess Margaret. He's not from Queen's. But, his fellow used to be Chris Booth used to be his fellow in the past. And Chris Booth was the person who was trying to get me to Queen's. He's my mentor. And Ian Tannock is mentor of Chris Booth. So in that sense, I call Ian Tannock my grand mentor. Anyways, so I have been inspired by Ian Tannock for a long time, but I had not met him in person. I had been to his talks. I had been in the audience when he was giving these lectures. I have read all of his papers, most of his papers, hugely inspired. So he was like a role model for me, but I had never met him in person. So he calls me out of blue. I was a fellow at Harvard. I pick up the phone. I say, hello. And the person on the other side of the phone says, hi, Vishal, this is Ian Tannock. And I thought someone was doing a prank on me because, this is the Ian Tannock, my role model. And I thought there was no way Ian was just going to call me. And I said, no, don't joke. Who is this? And that voice says, no, this is Ian Tannock. And then, Ian convinced me that it was a good idea for me to move to Queen's for different reasons, a variety of reasons. And so, yeah, Ian Tannock is one of the reasons why, or probably one of the most important reasons why I'm now at Queen's University in Canada. So Ian will be arriving soon for this podcast. Yeah, unfortunately, the setting is such that we are in this hotel. This is my hotel room, so don't mind the background. But I'm really looking forward to what we are going to discuss. Thank you. So welcome back. I am now with Professor Ian Tannock, my role model, a role model for most oncologists out there. And I call him the grand mentor because he's the mentor of my mentor. And he has several mentees all over the world, not just in Canada, all over the world. He's now retired professor from Princess Margaret Cancer Center in Toronto. And most importantly, today we are here for the Common Sense Oncology annual meeting. He has been a founding member since the beginning. And one of my privileges is that I get to work with him as a co-lead for the project clinical trials team under Common Sense Oncology. So thank you, Ian, not just for being in the podcast today, but for everything that you have done so far for oncology.
You're embarrassing me. Stop it.
And I think I should also tell this, that Ian has contributed a lot to global oncology education, including in my home country of Nepal. So he has several mentees in Nepal as well. And I'm proud to be associated with Ian in some way. So Ian, in this podcast we talk mostly about not anything core scientific, but the goal is that listening to your story, the audience will get inspired. And I wanted to know briefly from you, like, how did you start your journey into oncology and then into clinical trial space? And then what made you pivot from running clinical trials into, let's say, common sense oncology, for the lack of a better term, as in, how should clinical trials focus on outcomes that matter to patients, the issues about surrogate endpoints, crossover, informative censoring, all these issues that you teach about. What made that pivot from just running clinical trials? And you have run several important clinical trials, especially in prostate cancer and breast cancer. From that to being, in a sense, critical of poorly designed industry-sponsored clinical trials.
Well, that's a long story. So just to give you a bit of background, when I was an undergraduate, I went from my high school. I was probably like most a fairly lazy teenager, and I found doing math quite easy. And I found so I went to college in Cambridge, UK, uh, starting a mathematics degree. And I soon began to feel that it wasn't taking me anywhere I wanted to go, that it was very theoretical. So I had the idea of switching towards more medical things, and I did PhD initially in what was called biophysics. It was actually in the field of tumor cell kinetics.
Your PhD was in tumor cell kinetics?
Yeah, a long time ago. Long time ago.
Nobody would have guessed.
No, that's probably true. And then I did a postdoc in MD Anderson in Houston. It was probably somewhat accidental. I went there. The head of the department, which was experimental radiotherapy, was a man called Herman Soot, who unfortunately died quite recently. He came on a visit to the Institute of Cancer Research in London, where I did my PhD, and persuaded me to come to Houston for a 2-year postdoc. So I was doing experimental cancer research. I was working with animals. We were studying some of the factors that influence response to treatment. And I also associated MD Anderson with some of the people who were in medical oncology, people like Tom Fry, Emil Fry III, if you like. And we did some work on kinetics of human tumors. And I decided there, somewhat belatedly, that I would like to go to medical school. And I was fortunate to get into medical school in the University of Pennsylvania. I got a little bit of financial help, which was welcome because by that time we had a kid and a second one on the way.
So you went to medical school after you had your first kid?
Yep, I did indeed. Yes.
Wow.
My oldest son, who's now at the London University in the UK in the field of education, he was born in Houston, and then we
At
went.
the time, was it considered like, were you a bit late to go to medical school compared to your peers?
Well, yeah, I think the age I went to medical school would probably have been somewhere in the range of about 25, 26, that sort of age. And I managed to get through in 3 years. They gave me some credits for the science I'd done before. And then I came to Toronto as an intern and did internship and residency in internal medicine and oncology.
Why did you move to Canada?
I think at that time, my wife and I saw Canada as having some of the things we liked about both the UK and the US, without some of the things that we didn't like. And that's probably become much more extreme now with respect to the US. But the US was a meritocracy. They valued people who I think were thoughtful and did good science and good things. Whereas but of course, we didn't like things like, the guns, the gun laws, the flag laws, and so on. And the UK suffered from still being somewhat of an aristocracy, a little bit of sort of birthright to succeed. So we thought Canada was a good country, and we still think it's a very good country that combines some of the better aspects.
You were not dissuaded by the winter.
No, when we were young and the kids were young, we used to go skating, and yes, of course, we didn't like the cold, but no, we enjoyed the winter. No, that wasn't a problem. So I actually came to Toronto. I was an intern in internal medicine. Again, my past background of a PhD and a few publications got me a year off the training, so I did 4 instead of 5 years. And I always wanted to go into oncology because that's what I'd done. most people thought I'd go into radiation oncology, but
Yes, that
I,
makes more sense given your
well, I,
biophysics.
well, I
Yeah,
suppose it does. But
yeah.
on the other hand, when I thought about it, it seemed to me that obviously radiotherapy is a very valuable subspecialty, and I respect that. But ultimately, cancer kills people because of the disease spreads. And it seemed to me that the future was going to be more in terms of medical treatment and drug treatment than, I mean, still respecting, obviously, the huge value of surgery and radiotherapy for dealing with a local tumor. So I did 2 years of general internal medicine and 2 years of medical oncology at the Princess Margaret Hospital, as it was then, Cancer Center now. And again, because at that time I had established a few publications,
Mhm.
I was able to join the staff immediately after I finished my medical oncology residency, whereas other people would
Mhm.
most often go away for some sort of
Yeah.
fellowship, but I'd done that. So I stayed at Princess. I joined the staff at Princess Margaret Hospital. I think it was oh my gosh, I'm losing track of a bit of time, but I think it was around 1978 that I was able
Wow.
to do that.
So
Uh,
who hired you?
well, the head of the department was
Mhm.
Danny Birksale, who was a great gentleman. Danny was he was an expert in multiple myeloma. Um, And the training program at that time, which I think was good, and I'm sorry, it's in some ways it's changed, that everybody had a common first year in radiation and medicine. So you did 6 months of radiation oncology and 6 months of medical oncology, and the second year was entirely medical oncology. So I think that was
Mhm.
good. And at the time that I came on staff, people at that time treated more sites than they
Mhm.
do now. Often people treat only one site. Well,
Mhm.
when I came on staff, there was nobody treating GU oncology other than testis cancer.
Mhm.
And it seemed to me there were a few early signs that bladder cancer, for example, might be quite responsive. And prostate cancer was really a bit of unknown for medical treatment other than hormones. And so I was the first person to treat those diseases at Princess Margaret. I actually did an elective rotation
Mhm.
in the end of my residency with somebody who has been a lifelong friend now, Michael Jewett. And we still meet in our retirement. We still meet for lunches quite often. So I then did that. I also treated breast cancer throughout the time, and at the beginning also treated head and neck cancer, but I dropped that after a few years. And but for the rest of my career, I treated GU,
Mhm.
kidney, which we didn't have much for at the
Mhm.
beginning, bladder, which actually evolved into a disease where drug treatment makes quite a
Yeah.
difference, and into the initiation of chemotherapy and as well as hormone therapy for prostate cancer. So I think it was sort of quite opportunistic
Mhm.
because it was an area very hard for a young oncologist
Mhm.
now to come into a field
Yeah.
where there wasn't much going on.
Mhm.
At that time, the number of GU oncologists you would go to ASCO and it would be a small room, and that is
Mhm.
obviously no longer the case. So we were able to set up some studies in bladder and prostate cancer, and we had some interest in breast cancer as well.
Yeah. So how did you get from being a clinician with interest in GU and breast cancer to being a clinical trialist?
Well, I think it was I mean, I've always been research orientated.
Mhm.
I mean, I've looked. I mean, I think one of the things that I've done is I used to keep a book where I'd
Mhm.
write down ideas
Uh-huh.
for research projects.
Uh-huh.
And early on, it seemed to me that if nobody was using chemotherapy
Mhm.
for prostate cancer. Well, that's not completely true. There was an organization called the National Prostate Cancer Project, but they didn't do the trials very well. They were really weren't very good. And then So we started actually the first trial that I organized with colleagues in prostate cancer was actually a trial simply using prednisone. Prednisone will, of course, suppress the hormones coming from the adrenal gland. So, if you like, it was an early form of adrenal suppression that later on became much more expensive, much more effective with drugs like abiraterone. And we found some responses. PSA was just being learnt about at that time as a possible marker for following prostate cancer disease. And we did a small trial of, I don't know, somewhere between 20 and 30 patients that we treated with prednisone. And we showed that it suppressed adrenal hormones, and we got a few responses.
And these were investigator-initiated trials.
This was entirely an investigator-initiated trial, and we published that. I think.
And Princess Margaret supported you in doing this.
Yeah, well, we didn't need much support that time. We weren't in the days where we got thousands of dollars for doing clinical trials. I mean, basically, one of the things I started was at GU oncology rounds and worked closely with Michael Jewett, Mary Gospodarowicz, and others to get that going. And basically, people referred patients. You know, we recorded in the charts what we treated them with, and you know, we did their imaging, and which wasn't very sophisticated at that time. And when the PSA came along, we did that as well. And then we wrote it up. I don't remember having any external funding for that. And it was a time, well, you know, you could, if you needed a bit of funding, you could sort of get along. But, you know, apart from, you know, it was really your time for doing that. And another early person was Malcolm Moore, who was a long-time colleague. He was once essentially my fellow, became my colleague, eventually became my boss, which is actually the appropriate way that things happen. And we worked together very closely. We did a number of studies at that time. I remember one study I did with Malcolm, which was entitled, "How would GU physicians like to be treated if they had GU cancer?"
This is published?
Oh, yes. This is a JU. I'm pretty sure it's in the Journal of Clinical Oncology. It's JCO, probably in the 80s. And we had questions of surgeons and radiation oncologists and medical oncologists. Very interesting because when you came to prostate cancer, if we asked radiation oncologists how they want to be treated with localized prostate cancer, they would, of course, most of them want radiotherapy. If you ask surgeons, they would want surgery. The medical oncologists were a bit divided between the two. And one of the things that struck me at that time was that you know, the clinical trials were common to everybody. And yet it was so modality dominated that people couldn't think outside their own box. So that led to, I think, some critical thinking about clinical trials. And very early on, I was, I think, observing clinical trials as often people pushing things that weren't too justified. So I think I became critical quite early. One of my role models was a guy called Chuck Mortel. Chuck Mortel was at the Mayo Clinic, and he was very instrumental in criticizing clinical trials. He was a tough guy.
Even in those times, there were trials that needed to be criticized.
Oh, absolutely, even more so. In fact, I had an article in the very first issue of Journal of Clinical Oncology, JCO, which critiqued clinical trials in JCO issue 1, number 1. And there was an update about 25 years later when they had an anniversary. I can't remember what it was called, but it was, you know, things like using stable disease and so on. So we critiqued clinical trials. And then perhaps published in the 1980s, there was a paper with, at that time, I liked teaching residents and I've always liked teaching. And there was a guy called Joe Barr, who is still very strong. He's in Pittsburgh. I think he's probably retired now. And we wrote an article that was based on cancer of the great toe.
That's really
And this
good.
was an entirely hypothetical clinical trial. So what we wanted to do was we were concerned that there had been poor reporting of clinical trials, poor conduct and reporting of clinical trials back in the 1980s. And we wanted to point out these poor reporting and how it could be done better. And we soon learn, I mean, one of the things you're soon going to learn, if you actually take somebody who's published a clinical trial and start criticizing it in the public press, in the journals, you'll become very unpopular. So what we did
I
is
very much know about it.
so what we yes. So what we did was to yes, and I learned that too later on. But what we did was to create a totally hypothetical clinical trial and a hypothetical treatment that we called Kaboom, which was an acronym for the drugs that we used. And we wrote it up as a series of three parts to a paper. One was called something, effective chemotherapy for cancer of the great toe. And the other one was called failure of chemotherapy for cancer of the great toe. And the third was a discussion of why they're different. And they were based on the same data set
I see.
and different reporting. And in the paper on the failure for chemotherapy, sorry, in the paper that the effective chemotherapy for the great, all the dodges, all the biases were taken from articles that had actually been published in major journals. In fact, they'd all been published in a year's worth of JCO. And we even had false references. We had references to the New Scotland Journal of Medicine and so on. So it was a lot of fun. And I submitted it to JCO. It was.
Did you tell the editor that it was a satire?
It's probably the only paper that, and George Canellis was the editor of JCO at that time. It was probably the only paper that's ever been submitted to a major journal where the letter of submission says, and we assert that every piece of data in this paper was entirely fabricated and get it published. So that was very well. I got quite a number of frequent flyer miles out of that paper, and people loved the idea. People used to send me pictures of you get rare metastases to the great toe. So people would send me. So I think in answer to your question, Vishal, even though I was doing trials, and we come back to the trials that followed on from the prednisone trial, I think already from the start and perhaps it was this quantitative scientific background and radiation oncologists, I think, had always been more critical, that led me to be quite critical of the trials that were going on there.
No, most of the thoughtful oncologists that I have met, I think they have some background in mathematics and physics, because I think that helps to think critically.
I think it does. And also perhaps coming into the field a little bit older than the average resident or fellow, I mean, when I came through my oncology training in the late to mid 70s, this was a time when there was a great deal of excitement, quite justified. I mean, you had the ability of MOP chemotherapy to cure Hodgkin's disease, later BVD. You had huge improvement when you had people using, I guess, cisplatin was just emerging, and people were curing curing testicular cancer. So lymphoma, there have been advances, particularly in childhood leukemia. So there were certain diseases out there where suddenly drug therapy had made a difference. Leukemia, lymphoma, testicular cancer. And I think that, many of the oncologists at that time thought, well, this is the start, and it's only going to be a short period of time when all the common cancers are going to follow. We're going to be cured breast cancer, metastatic breast cancer, we're going to cure colorectal, lung cancer, etc. And as you know, that didn't happen. And people didn't understand how come we can cure diseases like testicular cancer, but we can't cure these others. And in part with that enthusiasm came this sort of, you couldn't be a denier. It'd be like denying motherhood, and so you had a lot of people making false claims, and a lot of the biases that you're very well aware of that came into to clinical trials. So I think that went on at the time. And I also was one of the first people to really start working with clinical research fellows who came to Toronto. And one of the things I did with fellows was to try to give them, and I think successfully, projects that led to reasonable publications. And some of the, I mean, the study I did with Malcolm Moore asking uh, uh, urologic oncologists of different disciplines, how they'd like to be treated. That was one of the sort of fairly critical projects we did, and a number followed that related to problems with clinical
Yeah,
trials.
so it seems like this critical line of thinking, there was no like a pivot moment that changed your thinking. You have always been thinking critically since the beginning.
Yeah, and the other thing that happened. So let me talk about the prostate trial. So the
Yeah.
second trial we did was a trial of mitoxantrone. Why did we choose mitoxantrone? We chose mitoxantrone because it's a very well tolerated drug, and we were treating elderly men, often with comorbidities. And as long as you stay shy of the doses that cause cardiac problems, mitoxantrone is extremely well tolerated as a chemotherapeutic agent. And I was also involved at that time with quality of life. And in fact, I was wrong. PSA hadn't yet been really established. It was halfway through the mitoxantrone trial that PSA started to be recognized as a potential tumor marker. And so we designed the mitoxantrone trial, and we thought the most important endpoint was a quality of life endpoint. And we selected patients with bone pain, which is the most common symptom of men with castrate-resistant prostate cancer.
And why not overall survival, Ian? Like at the time, you did not think that it was going to improve survival.
We did not, and it did, we thought we were looking at a palliative treatment. And we were looking after, I was looking after, with Malcolm Moore and others, people where pain control was a problem. I mean, we became pretty good at controlling pain and using narcotics and the analgesic ladder and so on. But there was one very small trial, the single arm trial of mitoxantrone, that suggested just a few patients that it might have some benefit. So we set up the trial. And to go into the trial, we first optimized pain control, and people had, and we used a 5-point scale essentially, and an analgesic scale, because obviously you could change pain with analgesic. And we required patients to have pain to go into the trial. And if they had 1 or 2 plus pain, the endpoint of response, they had to go to 0. And if they had 3 or more, they had to drop by 2 points in the pain scale without an increase in analgesic. And we had a co-primary endpoint where a 50%, we set up a numerical scale to decrease analgesia, and without the, so a secondary endpoint was a decrease by 50% in the required analgesia without increase in pain. So it was the first trial, and we had 161 patients. It was done across Canada, and the makers of mitoxantrone at that time was a company called Lederle, which I don't think is still operating. And we approached Lederle, and after some backwards and forwards, they actually gave us a huge sum of 1,000 Canadian dollars per patient to enter patients in this trial.
Oh, wow.
And about halfway through the trial, and it
was only Canadian patients? I forgot the demographics of the patient. It was US and Canada?
No, mitoxantrone trial was purely Canadian.
Okay.
And we had 161 patients across Canada, several centers.
That was when CCTG already existed? Like
Yes, we didn't
Yeah,
actually
okay.
run it directly through CCTT.
Okay.
Towards the end, we sort of did. We presented it
Uh,
to the emerging GU oncology group
I see.
and so on. So, and we finished that trial. There was a highly significant difference in palliation. I think in terms of the endpoint, it was about, and the comparator was prednisone. It was mitoxantrone plus prednisone versus prednisone. And the response rate was in the mid to upper 30% in terms of the pain control versus for prednisone. I think it was, I can't remember, 10 or 12%, something like that. So that was the first randomized clinical trial that I led and had largely designed. Martin Stockler, who you know is a very prominent oncologist now in Australia, was with me at a fellow at that time, and he did a PhD that was based on sort of validating the other quality of life endpoints we had in that trial. We did not see a survival difference. Probably it would be impossible to see that with 161 patients. We really didn't see any trend, but we did see palliation. And that was the first drug that was approved by the FDA and the EMA on the basis of a pure quality of life PRO endpoint. So, and actually remains one of the only ones because the later gemcitabine trial was a sort of bit of a mixture of patient and clinical. So that was the start of the clinical trials. And that led to mitoxantrone becoming the treatment of choice for castrate-resistant prostate cancer around the world. We made a lot of money for Lederle. They made a donation to our research fund that allowed us to fund some more fellows, but that was an entirely trial initiated entirely outside of a company. The later trial, for which I'm probably best known, is TAX 327, was different. So TAX 327 was the 1,000+ patient trial that established docetaxel, and there was another SWOG trial, but they used docetaxel with estramustine. I think my biggest contribution to prostate cancer was persuading the company not to use estramustine, which is quite toxic and really doesn't do anything. So what happened there was, having published the mitoxantrone trial in JCO, incidentally, New England turned it down.
Oh, really?
Yeah. But anyway, c'est la vie. It was Sanofi Aventis. I think it was Aventis at that time. It was based in Paris. And they got in touch with me, having led that trial, and they wanted to do a trial comparing docetaxel plus prednisone with mitoxantrone plus prednisone, which was the current standard of care. And so essentially, two people came over from Paris, and we spent 2 whole days in an office along from my office at Princess Margaret, and we wrote the basis of the protocol. And well, for that trial, survival was the primary endpoint. We maintained the pain response, and we had several papers that in several fellows wrote about long-term survival or the quality of life aspects and so on. So that trial initially I was the major player with a couple of people from the company in the design, and they were reasonable people. I think it was before the time the companies really started trying to influence things. Overall survival is the primary endpoint. Pain control and other aspects of quality of life were secondary endpoints. I think it was a good trial. Difference wasn't huge, but it was highly significant. And we had eventually, from around the world, more than 1,000 patients. There were 2 schedules. And they appointed a co-PI from the US and a co-PI from Europe, and together we ran that trial. Interestingly, when the trial was finished and we wrote it up, which was published this time in the New England Journal, I actually had to fight the company to write the paper. you know, this business of, oh, we'll get our medical writers to write it. And I said, no, no.
That existed in those days too.
That, yes. By that time, so that was published in just after 2000, I think 2001, 2002. And incidentally, it's still the same. It's still the preferred chemotherapy for prostate cancer.
Yeah.
That hasn't changed. So I wrote that. I think the compromise was that their medical writer could check my version for spelling errors and grammar. So we published that. And then there were a number of trials that they added all sorts of targeted agents to docetaxel. I think last count, there were 8 or 9 of them. I chaired one of them. But nothing improved survival. So that was the history of trials there. I was involved with 1 or 2 trials in breast cancer, but not at the same level.
And after that, you lost interest in doing trials?
No, not really. No, I mean, I participated in trials. I participated in the clinical trials group here in Canada. But I led one other large trial, which was a trial of docetaxel plus VEGF trap, one of aflibercept, which was a negative trial. I didn't really lose interest. For a number of years, people would ask me to sit on advisory committees where prostate trials in particular were being designed, which I agreed to do if it was a real advisory committee. I would never go for these marketing things. And I always put any honorarium into a research fund, which is how we funded our fellows. I mean, during the time that these trials were being done, and subsequently, as you know, we wrote a number of critical articles about trials, and I guess that's culminated in the one that we wrote that was published last year with the Common Sense Oncology Principles for design, conduct, and reporting of trials, for which you were the first and I was the last author. And that was very much as you know, a joint project with obviously input from a number of others in Common Sense Oncology. So I think that's continued. I mean, don't forget that I retired from active practice in 2014.
It does not feel like it. It does not feel like it. Ian is always traveling all over the world. And, like outside of oncology, I think he's a role model in the sense of if I can be as healthy and as active as he is at this age, then I would consider myself a huge success.
Well, that's very good fortune. It is. But I've always enjoyed teaching. Throughout my career at Princess Margaret, from the age of about 40 on, or even maybe a little earlier, I've always worked with fellows, and
let me ask you this: did you ever had a bad fellow, and how did you deal with that?
No, I never had a bad fellow who I felt was a problem in helping to look after patients. I had some fellows who have gone on to become research stars and residents. I mean, Chris Booth was not a fellow, he was a resident, but already worked with me. And people like Martin Stockler and some others, and some of them have leadership positions around the world. I have other fellows who they're pretty much all decent oncologists. And of course, another of my fellows was Suraj Nirala, who was doing very well, another Nepalese fellow. I would always restrict myself to not having more than 2 fellows. And I can't remember having a bad fellow, but I can remember that I had 1 or 2 fellows that weren't really turned on by the research. They didn't have that really inquiring mind, and that's fine. I mean, we don't need everybody to be like that. We do need people who are competent, of course, to look after cancer patients.
And Ian, you have seen this landscape of clinical trials change from from those days, 1980s, 1970s to today. Um, I was surprised that even for the tax 3 to 7, the industry offered to write the paper. Nowadays, industry prepares even the slides. So I
I,
find it very disheartening that even the slides at ASCO, ESMO that they present,
I completely
yeah,
agree.
it comes with a disclosure. And I'm like, at least we can make our own slides.
Yeah, and they write the abstracts.
Uh-huh.
I mean, so one of the things that happened up until about, I guess, 7 or 8 years ago was that Annals of Oncology had approached me
Mhm.
to write a series of editorials,
Mhm.
critical editorials,
Mhm.
which I did often with fellows.
Who was the editor-in-chief at the time? Surya?
No, it was before. It wasn't Jean-Charles Soria. Da. I'm sorry. Age does catch up with. I'll think of it in a bit. Um, and I,
Uh-huh.
and But basically, I wrote, I think, probably about 6 or 7 or 8 editorials. One of them was entitled "Have Investigators Forgotten How to Write?"
Oh, then it must have been Fabrice Andre.
Yeah, well, he took over, but
Okay.
even before Fabrice,
Mhm.
no, it was before Fabrice that I continued that.
Mhm.
Where, but I wrote that. There was another one you that I wrote that was called
Disclosure in the blink of an eye.
"Disclosure in the Blink of an Eye." How long was the disclosure slide shown for at ESMO? And I must admit, Vinay Prasad and his colleagues had written a similar thing for ASCO. So it was 4 seconds
Yeah.
was the answer to that question. So we wrote a number of critical editorials that pointed out these problems in clinical trials. And there were early papers also pointing out problems with clinical trials, written with people like Aitan Amir, who
Mhm.
has continued doing that sort of work at Princess Margaret, Bastian Saruger,
Mhm.
and others who were
Mhm.
fellows at Princess Margaret.
Mhm.
And we had papers also in Lancet Oncology
Mhm.
in that vein before. So yes, I mean we've continued to
Mhm.
push that.
And Ian, like nowadays, when you look at how the landscape has changed in terms of problems with trial design and conflicts of interest, you have been very vocal about these issues as well. Like when you look towards the future, are you optimistic or pessimistic? Like, does it provide you hope? Do you think we are doomed?
Well, the
Uh,
world is in a particularly bad place in April 2026, as you well know.
uh,
I'm a little bit optimistic
uh,
in the scientific area because I think there is more realization that things are disturbingly biased at the moment. The fact that we have had the development of therapies taken
mhm,
over entirely, almost entirely by pharmaceutical companies, and I'm not suggesting that they haven't produced some good drugs, and I'm
mhm,
not suggesting that some of the people in pharma aren't good, thoughtful people, but the dominant people are the marketing people. And they will do whatever they can to sell their drugs, and unfortunately, that's the state at the moment. It does grieve me that some highly intelligent oncologists have been willing to lend their names to a process, so-called key opinion leaders whose names you see time and again on the same papers, who are absolutely aware of the biases that are in clinical trials, um, and yet are refusing to
mhm,
say, no, I won't take part in this
mhm,
trial because of that. And they know full well
mhm,
that pharma will find others to
mhm,
do it. But I think that is a bit of a shame. The encouragement comes from organizations like Common Sense Oncology, the Optimal Cancer Care Alliance, Choosing Wisely. So there are a number of organizations and involving patients more that are beginning to say enough is enough. And as we've seen recently from at least the Lancet journals, we've seen their willingness to recognize that these things are wrong. It still grieves me that, I actually lectured the fellows at Princess Margaret last week, and I talked about problems with clinical trial. It does grieve me that not many of them actually know about major causes of bias. I mean, they, I think, can reasonably assess a question. They can reasonably assess a control group. Very few of them have any idea about informative censoring, which is probably the biggest hidden cause of bias in trials. And I think we really need to push education in critical thinking. And it does grieve me that a huge proportion of oncologists are accepting personal finances from companies.
Yeah, and even in my personal interaction with many oncologists, some of them are like, they are pretty thoughtful in personal interactions, and many of these people are like amazing people to hang out with. But then, as you said, in the public forum, they never speak out against these trials, and often they put their name behind these trials. So, do you think you have a lot of experience in this? Do you think this is just personal greed, or like the expectation of professional growth in career by doing that, or like why?
Well, I think it's probably I think non-financial conflict of interest, personal advancement probably. I suspect the people who give their names to these multiple first author articles in, that may be published in the New England or other leading journals, I suspect that personal environment is probably counts a good bit more than the few extra $1,000 a year that they may receive in honoraria. But for whatever reason, I think it's a bad thing. And I think it's very sad when you see people accepting that. I mean, in general, if you're going to be bringing on younger people, you allow them to take the lead in trials, but you also stand firm in terms of when clinical trials are being written by, well, I mean, medical writers are probably on the way out because it's all going to be done by AI, and AI is hugely sycophantic. So it will produce reports that are exactly what pharma wants because that's what pharma will ask for. So I think that is a problem. On the other hand, we do have a situation where we can't go. I mean, as you know, the amount that we spend on oncology is going up and up and up relative to everything else, even other drugs, but to all other things in our life. We want our kids to be educated, our roads to be mended, and so on. I don't think that can continue indefinitely. And so I do think there's got to be some, damping down of this very commercial aspects of that we are seeing.
So Ian, like one of my goals is to inspire the next generation of mentees, trainees, oncologists, because I think that if someone is into oncology residency program, like what would their goal be, right? Their goal would be to, I guess, be the first author of New England paper, to be at the ASCO podium, ESMO podium, give talks, but they look up to these role models, and most of the role models, unfortunately, are people with conflicts of interest who are there because of all these activities. So, like, what would your advice be to someone who is a fellow, let's say, a fellow in medical oncology who wants to do good work, but then he or she looks up to role models, and most of the role models are people with biases and conflicts of interest. So, what is your message to them?
Well, I think my message is to try to develop your research career so that you are respected. Um, I mean, you and I both teach in courses like that.
Hmm.
I outline the problems of
Hmm.
being known as somebody who is only sort of working along with companies. And I mean, when I teach at the week-long clinical courses like Credo, and I've
Hmm.
taught at all of the ones around the world, the American, the European, the Australian one, I try to encourage people to develop their own research programs, and you need to start relatively, doing studies that you can actually do and publish, and also to work with a mentor who is going to give you good advice about treatment, and not just somebody who is, wanting just all of the limelight. So that's how I would encourage research-oriented people to develop their career. I've probably been fortunate that I could, you know, have done one or two major trials
Hmm.
that are well known before it became common that drug companies, pharmaceutical companies would sign up people who would be willing to go along with pretty much whatever they wanted. Um, but it is hard for younger people
Hmm.
these days to do that.
And Ian, on the flip side, what do you think makes someone a great mentor?
Well, I think, I mean, they've got to have an ability to teach, to explain things. They've got to have patience, and they've got to have, I mean, they're going to be, I mean, they're a good mentor for clinical work is they've got to be good clinicians,
Hmm.
and they've got to show people and let people do their own thing. In the research side, I think it's important that a mentor have ideas that they
Hmm.
can give to younger people to stimulate them to do a study,
Hmm.
and then help them to do it,
Hmm.
and let them take also the major credit for it. So I think those are the probably the main things.
Hmm. And Ian, yeah, we are towards the end. I wanted to ask some personal questions, as in you wear different hats, as a father, as a grandfather, as a husband, and as a teacher, as a mentor, as a researcher. What is your favorite one?
Oh, that's not fair. It's like choosing between your children. Yeah, you don't have to do that. No, I mean, I think you
Yeah.
try and fulfill your role in
Yeah.
whatever that role is, right?
But how do you manage time for everything? Because I need to tell the audience that if we are planning any project, usually what happens is the mentor delegates the work to other people, and then and the first author does a lot of work, and the mentor critiques on the draft or whatever. But Ian, he more often than not, he writes the first draft himself.
No, that's definitely not. That's actually was not true when I was supervising fellows at Princess Margaret. No, they would write the first draft. When they had a symposium when I retired, one of my former fellows, Rachel Riekelman, who is another of my fellows who's in a very senior position, she came and she gave a talk where she did a mock-up of the one of the fellows' first drafts with my red ink all over it. I
Yeah.
mean, it was fabricated, but it
Yeah,
was,
we have something called the Eon's evil red pen.
yeah.
Yeah.
So they laughed at me.
Yeah.
So no, I did not write the first draft of the
Yeah.
papers of my fellows. I did critique them, and
Yeah.
I think I hopefully helped you to write better. It's more with common sense oncology, and you've got to remember that most of the people in common sense oncology have a day job. I don't have a day job. So I do teach around the world, and I travel a bit, and including in some lower middle income countries like Nepal and India and Vietnam. But a lot of my time I'm actually, at home. And of course, during the 2 to 3 years of COVID, I was at home. So and there, I mean, my day at home is often I'm doing things on my computer. I may be preparing talks, but I may also be writing. And I have the time to put in to write some of the drafts for these papers for Common Sense Oncology. But that's different to writing. I don't write
Yeah.
papers for
When
others.
when you were active in your clinical practice, how did you manage time? Did you find it difficult to manage time for everything? Because right now, from my standpoint,
Yeah,
very much we struggle. Yeah,
you have a wife and young kids.
yeah,
So my wife was also a professional.
yeah. I had the pleasure of meeting her a couple of weeks ago.
That's right. We
Yeah.
were in Rome together. So my wife was as well known in her field as, well, it sounds a bit boastful as I am in mine. She had larger grants than I did. She works with learning deficits and so on. So she did a lot of traveling too. So once the kids had got older, that wasn't so difficult. We would do things together, but during I mean, particularly COVID was a big challenge for a lot of people. But we would work. Well, she now paints. We would go for a walk. But when the children were smaller, it was harder. I mean, my kids now range from 56 to 48, so it's a long time ago. But when they were younger kids, we always protected meal times and bedtimes. I mean, it was tough for my right. I mean, when you're going through a residency and you're working one night in three or four, it's obviously very tough.
Mhm.
But once that eased, we would both work in the evenings, but we would protect meal times
Mhm.
and story times and things like that.
Mhm.
And we always had holidays. We always had
Mhm.
family holidays. So
Yeah, and what did you do as a hobby, or what do you do as a hobby even now? Like, what is your pastime? Do you watch movies? Do you listen to
yes, we do. In
Yeah,
fact, we when we were younger, we were quite movie buffs. We used to watch.
really?
Oh yeah, we used to watch a lot of what would be considered art movies,
Uh-huh.
French movies, and so on at that time. And during COVID, I mean, particularly, and since then, we often stream a movie in the evening.
Mhm.
Sometimes older movies, sometimes newer ones. Um, we we read a lot. We I was reading something.
And did you play sports?
Yes, but not terribly well.
Uh,
My
Okay.
my eye-hand coordination is not great. I used to play. I ran and I run with some friends. I walk with some friends now. I have a group of friends that we meet 2 or 3 days a week. I now walk because I have had I haven't had major health issues, but
Mhm.
I did twice have operations for sciatica and then more recently for a hip replacement, which is remarkable how easy, well, that is these days. It's but I stopped running a few years ago now, but I meet friends and we walk and we meet for coffee
Uh-huh.
and we change the world and things like that. So we do that. We go occasionally to concerts. We go to the symphony. We occasionally go to the opera.
What are your couple of favorite movies, Ian? I just wanted to get a sense.
Oh my gosh! Now I have to just think. Maybe things like I can think of One Flew Over the Cuckoo's
Oh
Nest,
yeah,
Jules Jim, one of the
got
old
it.
French movies. Yeah,
Okay. Uh-huh.
it's. I mean, more and more would come
Yeah.
to mind if I
Yeah.
thought about it. More recently, movies like Parasite and
Oh, okay. Okay.
yeah,
Yeah.
I've enjoyed a lot of movies.
I guess we are towards the end. Thank you very much, Ian, for your time and for your mentorship. I'm very grateful that I got the opportunity to learn from you, as well as, yeah, at the end, if you have any message for the audience, I guess most of my audience are young trainees in oncology. If,
Well, if you're young trainees in oncology, please learn to be critical. Very good to go to some of the courses on critical thinking, and keep your independence. I mean, it's fine to be involved with clinical trials, but be critical of them and just remain independent of pharma. Don't Most of you hopefully are reasonably well paid. So if pharma wants to give you money, use it to put in a research fund and hire fellows and students and do some research with it. Don't put it in your pocket.
Thank you very much, Ian.
Okay.
Bye.